Okay, great. We have folks coming in. Hi, everyone. Wonderful. Okay. Welcome in, folks. We're going to get started in just a minute. Thanks for being here with us.
All right, so it's 10 o'clock, might as well start. Welcome, everybody. Thank you for coming, especially in the middle of our days. But we're very happy you're here. My name is Feldman. I'm the director of street medicine at USC, and also the vice chair of the International Street Medicine Institute. My role in the institute is to provide consulting and technical assistance to our members. We have about close to 200 members around the world, and I've been doing street medicine since 2007. And I'm joined with other panelists, Kaitlin and Laura. Kaitlin, do you want to introduce yourself first?
Yeah, hi, folks. My name's Kaitlin Schwan. I lead the California Street Medicine Collaborative, and I'm an associate professor of family medicine at USC, and serve with Brett on the Street Medicine Institute board. And so thrilled you're here. Over to you, Laura.
Hey everyone, Laura Brennan, she, her pronouns. I'm Senior Policy Manager at National Healthcare for the Homeless Council. I lead our federal policy work alongside Barbara DiPietro. It's good to be here.
Great, thank you. And so you all are here for the U.S. Street Medicine Research and Policy Agenda. It's designed to be a living roadmap, not something that is static. And basically, as many of you know, street medicine has been around for 30 years, and part of the question is, well, why did we decide to build a roadmap now? And we're at this really interesting time in street medicine where throughout our history, we've been really this like radical fringe movement. And now for the first time, we're being incorporated into mainstream healthcare. And that brought about a lot of questions, like how do we not how do we bend and mold street medicine to fit into mainstream healthcare, street medicine, which we know works, mainstream healthcare, which hasn't worked for this population, but rather how do we bend and mold the system which to fit street medicine, which we know works. And all this was done prior to HR1 and some of these other newer things that have happened at the federal level. And we didn't anticipate the system would be bending on its own um, without in ways that we hadn't anticipated. But all of this is still going to be very valid. And just very quickly, how we ended up hosting it at USC, we have four arms to our program, a clinical arm, which actually delivers street medicine, workforce development and education, which trains others how to do their work, mostly in California, but nationally as well. A research arm, and then a policy and advocacy arm, which houses the California Street Medicine Collaborative. That's what Kaitlin oversees. And that's where we do our policy work out of, which has been national and state and and local. And we got a grant from the Doris Duke Foundation in order to hold this summit to answer some very key questions. And so the questions that we came to with the summit were, we know street medicine works for the people, but how do we prove it? Um, what do we actually mean by works, and what do we mean by prove? We keep getting asked all the time, how are we defining quality and making sure that we can provide good quality care for our patients? We're told all the time we need more data, data, data. Data for what? Data for who? Will the data actually change your mind? Like if we just had this one data point, it would open all these doors for us. We're always told street medicine doesn't fit into traditional healthcare delivery structures. Well, if it doesn't fit, then what would the ideal look like based on the reality of the street that we witness when we go to people? What's the ideal payment structure to support what we already know works? And then what's needed to scale street medicine from like a policy level or research level? Of course, you need people doing the work. And then finally, how does street medicine fit into the housing continuum? In some states, like in California, healthcare is being asked to participate in housing. And so what does our role look like? And many places that there's already a housing infrastructure. And so with that, we invited um, lots of different people from different backgrounds from all around the country, from experts in street medicine, people with lived experience, and expert researchers in this field, from diverse geographic regions, diverse backgrounds, diverse levels of experience, and met in Washington, D.C. With the summit. And some of the background that Kaitlin will go more into, and then ended up publishing this street medicine agenda, which we'll go over with you today. And before we get started, it's just important to talk about what's the background of street medicine, like where are we right now, understanding that in the greater context that this is an international movement, and these are some of the places that street medicine is internationally. And as you go around the country, you realize that there are some ways in all the different places that we are, some things that are standard and some things that are customizable. And so that's part of what we were trying to determine in the summit. But before we get any farther, it's important to that we're on the same page on what's the definition of street medicine. So we were talking about the same thing. The historical and global definition belongs to the Street Medicine Institute, which actually also owns the copyright to the term, which defines street medicine as care delivered to unsheltered homelessness in their own environment. Now, for the first time, it's been almost exactly 2 years, the federal government has defined this with a new place of service code for people on the street or found environment, not described by any other place of service code, such as mobile medicine, which is 15, for care delivered specifically to unsheltered individuals in their own environment. And this is also what allows us to get reimbursed for our care, which is now national. And part of the reason why we have to do it this way is we, we have come to realize, if anybody's been on the street for any amount of time, that having health insurance does not equal access to care. And most of the data that we have about people experiencing homelessness is system-centric, where first they come to us, first they access the system, and then we ask them things. And so we wanted to know what's the total denominator. And so we went to the people on the street and asked them, do you have insurance? Are you seeing a PCP? And found in LA, 75% have insurance, but only 7% are actually seeing the PCP. And it's not because they're healthy and they don't need a PCP. And so that's part of the reason why we go to the people. And it looks similar in many, many different cities. When we go to the people, what is it that we're doing? What's our scope of practice? And there's always been this question, is street medicine primary care, transitional primary care, and can't quite make it to primary care? And what we discovered that not only is street medicine primary care, but it's primary care plus things that you wouldn't typically find in a brick and mortar clinic. We found over 70% are providing full scope primary care and preventative medicine, plus care for behavioral health. 80% are bringing medicine on the street and dispensing them on the street. 50% are drawing labs. 60% are doing MAT on the street. This is very, very common. 40% doing ultrasound on the street and much, much more. And more recently, we've seen the development of street psychiatry, which has expanded a lot. Very, very high levels of SUD treatment on the street with long-acting injectables like Suboxone and Brixadi. Again, this has become extremely common. And even reproductive health on the street. These are photos of a T in Dallas and Camilo in LA doing prenatal ultrasounds on the street. So really just more sophisticated than I ever imagined. Um, and we've really also started calling out some things that we noticed that are different in the systems and why there needs to be um, adjustments to the system. So in traditional primary care, patients come to the office. In street medicine, it's a search mission. This will always take longer and will lead to less volume. In traditional primary care, you pre-screen for insurance. So a patient calls, sorry, we don't take your insurance. You have to go somewhere else. In street medicine, we see everybody and figure out, well, hopefully we'll get paid for some of this later. So it's higher unreimbursed care. In traditional primary care, you're assured of consent. They've made an appointment, they've driven there. You know that when it's time to sign the consent to treat, they will sign it. They've been through all this trouble. In street medicine, we might take a few attempts to do outreach before they ever sign the consent to treat, and so you haven't been reimbursed for that care. In traditional primary care, the patient completes the orders. If I order medication and an x-ray, the patient does those things and then comes back. In street medicine, we complete all these orders. In traditional primary care, no-show means you have 15 minutes lost, and if there are visits every 15 minutes, I can still bill for 3 visits in that hour. But in street medicine, if I can't find a patient, I'll search for them for a long time, sometimes up to 2 hours, depending on how concerned I am. And with all this, the provider's billing supports the non-billing staff, both in traditional primary care and street medicine. So you can see how this could cause problems in sustaining your program. And just to go over additionally, some of this, how this is complicated, all the different scopes of practice of street medicine, and the ideal would be to get reimbursed for all of the things that you're doing. If you're spending time doing it, it would be nice to be reimbursed for it. And so one is the traditional healthcare functions, which we've been talking about. We also provide for a lot of the human necessities and non-primary care medical services. Like, as I mentioned, transportation, medication, supplies, we pay for them, even if they're insured and the insurance company should be paying for them. We have this important public health role where we're constantly dealing with outbreaks of lice, syphilis, scabies, typhus. Every year there's a typhus outbreak in LA. And when we get called by the Department of Public Health that the ER has discharged a patient that was positive for syphilis, we need to find them to give them their penicillin. We're not reimbursed for that care. That's a public health thing. Or if we have a patient with scabies, we have to treat the entire encampment scabies, not just the one that we saw. And then finally, crisis prevention and post-crisis management, where we're getting referrals from people, we're finding folks in the midst of a crisis, whether it's, a mental health crisis or even a acute drug overdose. And like about a year ago, I found somebody that was standing on a bridge, ready to jump off the bridge, and thankfully talked him down, but it wasn't the time to ask for his insurance card to bill. And a lot of this work has led to a rapid growth in street medicine. When we did the landscape analysis just a few years ago, there were 26 programs in California. Now we know of at least 73. Um, the rate of growth has always been incremental throughout the country, but it has accelerated, probably not to the extent of California, but has still accelerated since the place of service code. And as I mentioned, there's so many people interested in this work now. Of the 275 member organizations in California, of course, there's street medicine organizations, but there's community-based organizations, over 20 managed care organizations, different government organizations. So it's really been a very collaborative effort in trying to figure out how to incorporate street medicine into the mainstream. And with that, I'll hand it over to Kaitlin.
Thanks, Brett. Wonderful to see so many friends here. This is just very exciting. Thanks for being here with us. Um, as you all might imagine, when we kind of went on this journey of trying to identify what is the agenda for street medicine for research and policy, we wanted to start with folks on the street themselves. We really wanted to understand how folks are articulating the challenges they're experiencing, what they want from their healthcare system, what their reflections on street medicine are. So I wanted to share some of the findings from this research that we did February to April earlier this year. We connected with 151 folks living outdoors in 6 different cities. I know there's representatives from all those cities here. We went out with street medicine teams who were generous enough to take us out. So thank you for what you did and creating this opportunity for folks to inform the agenda. These are the cities we went to. We really sought to do research in a diversity of spaces, cities that were larger, smaller, different policy challenges, different approaches to harm reduction, kind of you name it. We really wanted to get a diversity and go north, east, southwest, and had the honor of meeting with folks in their homes, whether that was under bridges, in RVs, in tents, all across the country. And what when we looked at the research, what we really found, and this probably won't surprise most of you, is that the experience of dehumanization was this overwhelming theme across every interview. And I was able to kind of pull out these three components that I want to talk about, that I'm kind of describing as the architecture of dehumanization on the street. So in all cities, a criminalization of survival and a denial of basic necessities, alongside systemic exclusion, discrimination within the healthcare system and other systems, and also the destruction of community and conditions for care, which was really, really important. And so I want to share those with you before we get into our agenda. So the first piece, again, this won't be a surprise to many of you on the call, but kind of the top challenge that folks spoke about was the criminalization of their very existence, and the profound denial of basic necessities for life. And what I've found is it can be very hard for folks who are housed and who aren't doing the work we're doing to really understand what that looks like. So I find it very helpful to articulate examples like washing a colostomy bag in a bucket of rainwater and reusing it until the plastic melts, or using balled up newspaper instead of sanitary napkins, not being able to sleep because the hunger pain keeps you up. These are the kinds of things we heard across the country. Met with a man who was arrested for bathing in a river because he had no other place to bathe. A man who was ticketed in New Mexico for using wet naps to clean his hands. These are repeated experiences that accumulate and create profound trauma for the folks we serve, in addition to resulting in pretty severe illness, disability, and in some cases death, because folks have a cut and it's not like getting a cut when you're housed. You don't have access to clean water to clean the wound. And very quickly, there was an escalation of illness. People spoke so deeply about the kind of systemic exclusion they experienced in the healthcare system. As you all know, there's profound access issues related to transportation, not having a phone or address to have mail sent to, competing survival priorities. So whether that's needing to collect cans or panhandle, and increasingly concerns about deportation and arrest really being profound barriers to going to EDs or FQHCs. And for folks that did arrive there, often faced pretty profound insurance challenges. It was very interesting. Across all the states, folks talked about unexpected cancellations in their insurance, really not being sure how to navigate their insurance, the copay costs being too high or having bills they didn't know about, and having to navigate really complex system labyrinths in this process. What was very painful to hear about, and I suspect all of you are also familiar with this, is just real concerns about the quality of care when folks get to an ED or a clinic of some kind, feeling that they're receiving poorer care because of their housing status, they're being misdiagnosed or mistreated with really severe consequences, refusal from providers to treat pain, or being treated without consent, with fentanyl or other opioids that folks requested they not be, and just generally poorer treatment on the basis of being unhoused, being turned away, bumped down on waiting lists, put in a quarter, dismissed, not listened to. And what we found is that, again, in all cities, there's repeated instances where folks are saying, I will risk death and serious injury, including disability, in order to avoid the experience of being dehumanized in the way I have been within the healthcare system. So a really profound indictment of the mainstream system's ability to serve folks who are unhoused. And the third piece here that is really important and very moving, in all the communities we went to, we found really complex and beautiful ecosystems of care, communities working together to meet each other's basic needs, navigate health crises, keep each other safe, support each other's sobriety. It looked like a huge range of things. And I found that in the interviews I did, folks most often broke down or struggled the most when they couldn't maintained the kind of care they wanted to provide for someone in their community or a partner, a loved one, a family member. Often people were prioritizing other people's health over their own, including their cats. Met a man who's, I said, do you ever have to choose between your cat eating and you? And he said, no, 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 my cat always eats. And really, this was a depth of meaning and quality of life for folks. Across all communities, again, post Grants Pass, huge escalation of encampment sweeps, criminalization of living outdoors, and the destruction of community being a tremendous challenge. What I learned from folks is that this dehumanization doesn't just involve dignity violations for oneself, but also the destruction of the ability to provide or express care to people you love, being deeply, deeply painful. The wonderful news is this street medicine is just loved across the country. Every single person we spoke with wanted to see increased investment and scaling of street medicine. Often it was, street medicine providers were the only trusted person or organization. Folks said either I wouldn't be alive with street medicine without street medicine, or I wouldn't want to be alive, and just a real deep belief in this field's ability to succeed where other areas of care have fallen short. So we're so grateful to all of the folks who really shared their expertise and informed this agenda. And I'm going to pass it back to you, Brett, to get us into the agenda itself.
Sure. So the group in DC came up with 9 key priorities. We're going to go through them rather quickly with you. There's a little more detail in the actual document. Go ahead, Kaitlin.
Mhm.
You can just click through. So the first priority was to establish national standards in street medicine, which I think came from this idea that if we don't know who we are, it's hard for other people to know who we are too. And then also we keep hearing, if you've seen one street medicine program, you've seen one street medicine program, and that simply can't be true. If so, then there's no standard. And so the idea was to balance standardization and customization. In street medicine, there tends to be more customization, but what can be standardized? And so the very first priority, which was to develop a taxonomy of street medicine, define different program types, the scope of services, create some sort of a tiered framework. Part of what landed this number one, honestly, was from advocacy from Jim O'Connell, who talked about how they did not do this with the medical respite movement. And they had what would be considered a skilled nursing facility level of respite. And then people were starting respites in many different places, even having a bed or two in a shelter that a nurse would stop by once a week and call it a respite. And one, it's difficult to know what to pay because the payers don't know what they're paying for. People don't know what the standard is and what they should be providing. And it's been hard for him to keep up the sniff level of care when people get the same rate for a nurse stopping by at a shelter once a week. We thought it was important to establish quality metrics to evaluate impact across all different um, physical health, behavioral health, and even our role in housing, which has become increasingly apparent to support the integration into the broader system. And we've started some of this work. For example, we began with the HEDIS measures, decided what ones are not relevant to us, um, added some measures that were very relevant that were not included in HEDIS, and then looked at HEDIS and said what needs to be changed but is relevant. For example, patient experience. The patient experience survey in HEDIS is irrelevant, but the idea of getting patients' feedback is very relevant. So we need to develop our own patient experience survey. And of course, all of this based on the reality of the street. Otherwise, we're just regressing into a system that we've wanted to leave.
Second priority, and this was the top priority for folks who are living on the street, is really the field's ability to try to advance access to food, water, and hygiene for folks who are living outdoors. So street medicine has this really unique, both like access to information about what it looks like on the ground when folks don't have access to these basic necessities. And also just like a ton of social capital as a field to be able to advocate at the federal level, at the state level, but also at the local level for public health infrastructure. This was really, really deeply a request. We had a huge conversation about the right to hygiene. What does that look like? What is street medicine's role? But many folks kind of articulating there is a real opportunity for street medicine to be partnering with governments to expand access, but also support peer and community-led efforts to provide food, water, hygiene facilities. So for communities to who are living on the street to provide that for themselves as well. We had our friend Eric Rivers join us from Pennsylvania talking about a water filtration system that he supported an encampment to implement. So it attaches to this bucket of water. It could be rainwater, river, water from the river, takes out microbes and sediment and other kinds of little bits that we all don't want in our water, and enabled the encampment to have access to clean water, which was a huge struggle for them. So folks on the street are both asking for us to really engage in providing these basic necessities while also doing the advocacy to ensure there's really broader public infrastructure around this. It is such an indictment in such a wealthy country that, for example, in LA, what we find is folks who are unhoused, a majority of them in terms of how they're getting their water, they're buying it. This is remarkable. And we kind of need both to be doing the advocacy work and also thinking about where we can leverage our expertise and our social capital to supporting progress in this area.
All right, just adding one more thing to that. The recent study we published showed that in LA, about 30% of people are eating 4 less meals a week. So this is more than food insecurity. This is starving, and you wonder why they can't make it to the brick and mortar clinic. Priority number 3 is payment mechanisms, which everybody loves to talk about begrudgingly. One is to figure out what would an equitable payment model look like. And so right now, most of the payment models are based on the shared risk, which involves large populations with relative, there's something called a relative risk ratio, which risk stratifies the population, one being the general population. If you're less than 1, you're healthier. If you're over 1, you're less healthy than the general population. And overall, within any particular clinic or health plan, it should come out to about 1. And that assumes that those that are healthy aren't coming, and those that, which is about a third, by the way, and those that are less healthy come more. In street medicine, just experiencing homelessness, not even unsheltered, has a relative risk ratio of almost 6. It's the highest relative risk ratio. Number 2 and number 3 are mental health and substance use disorders. So you can imagine the additive effect. And 100% of our patients are engaged. We don't get that third that never come because it's an assertive model. And when they come, they cost the managed care organization 6 times more. But so we are bearing, from a purely financial viewpoint, we're bearing all of this risk. So we've explored bundled payments, which would include, you can't just go out with a provider. You need community health workers, people with lived experience, nurses, and others to make it work. So it includes other discipline plus these medically necessary services, the idea that we're also dispensing medications, for example. And so similar to an ACT type of team are some of the things that we're exploring. And if that's what's needed, what would a fair rate be? We wanted these mechanisms to be inclusive of everything that's needed on the street. And again, build your programs based on the reality of the street. So how do we include behavioral health, SUD, housing services, um, different diverse organizational types? Right now, there's people of all organizational types doing street medicine. And how do we make that payment equitable? Where an FQHC will get a PPS rate of, say, $300, and a hospital will get the standard Medicaid rate of $20. But everybody needs to help in this work. And then erode silos so that that scope of work that I talked about can also be incorporated. So how do we pay for our public health role, our crisis role, in addition to just the more traditional healthcare role?
Mhm.
Next.
Oh.
And then HR1 and work requirements. So this will have a profound, profound impact. on our patients' insurance and ability to bill insurance. Um, I was I've been doing street medicine since prior to the ACA, prior to Obamacare, and we would have, maybe 5% of people insured. California is an expansion state. We have 75% of people insured, and you can passively hold insurance. Now you're going to have to certify that they have an exemption of like mental health or substance use disorders. So all those people, the 93% that are not engaged, will not have insurance anymore when you meet them. They'll have to be actively engaged. And we can't do what we did when the ACA was rolled out, which would send enrollment specialists because they need a provider to give them a diagnosis. So this will totally change the landscape of how we can get reimbursement.
Oh, whoops.
Oh. Next is building the evidence. So this is the research. The group in DC wanted a national research collaborative with the idea that most people in street medicine are just like doing street medicine. We don't have this big research chassis that can pool data, and so this was our way of pooling resources in order to pool data. And some of the research topics is national landscape analysis, similar to the one we did in California. Thankfully, we've already gotten funding to do this. So look out for some emails for us. We wanted to evaluate street medicine's impact on patient outcomes, our monetary value. I purposely did not write cost savings here because in healthcare, it's not just about cost savings, but about health outcomes per dollar spent. So right now, if they're paying for healthcare that people aren't getting, that's really bad uh, investment. And then what's the added value to government and social service delivery, such as the public health and crisis interventions, and street medicine's role as outreach? Turns out street medicine is actually really good at just doing outreach and building relationships quickly.
Fifth up, so this was really important. A lot of folks felt that we really need to strengthen the national and state infrastructure to support the expansion and scaling of the field. So one of the things we've done in California, we have the California Street Medicine Collaborative, and there was interest in DC around developing similar either state level kind of collaboratives or regional. Um, in California, what we've been doing with the collaborative, we have like a monthly all-state meeting where we go through kind of big policy issues or challenges we're facing. We have a clinician learning circle. We host various webinars. We have what's called educational action groups where we do a deep dive for a few months on a particular topic. But really, this kind of organizing and community of practice was part of a desire that came out of DC that we really need to be doing this at the national and state level to support this like exchange of knowledge and do collective problem solving. Obviously, lived expertise really needs to be at the forefront of this in all leadership levels. That was really clearly articulated, and that the time might be very ripe for this kind of work right now. We're facing, we all say, unprecedented challenges for the field, but for folks outdoors as well. So developing this kind of infrastructure is going to be critical around policy advocacy, but also just adaptation and learning as we go along. And related to this was, we're seeing a real excitement around the development of specialized street medicine workforce and education. So at the federal level, there's been the HIV SPINS HRSA grant. There's been grants around street medicine residencies. There's increasingly a recognition, both at federal and state levels, that street medicine is a field that requires specialized training and investment in education for this field. So the folks in DC really felt it would be helpful to have street medicine curricula in medical schools and residency programs. In other fields, that we need to be developing CE accredited training in trauma-informed care, social medicine, and that we need funding to support the specialized workforce in order to kind of create a pipeline into the field. seventh up, and I'm kind of running through here, but what's wonderful is many street medicine teams are deeply engaged in supporting folks to exit homelessness, get off the streets, get into housing. What we found in our meeting in DC was that the models for doing this varied really considerably, and that teams were often looking for best practices or different models they could look to think through both how to do this, but then also to how to capture data on improved health and housing outcomes. So there was a real interest in exploring pathways for street med teams to be engaging in medical respite, the housing navigation process, doing post-housing follow-up. Can we, as a field, create really detailed and consistent measures regarding housing status and health that could be tracked over time? Incredibly helpful for us in a variety of ways, but including for field building. And can we create standards of care around what the intersection of health and housing looks like? We know that housing is healthcare. Can we think about standards of care during housing transitions that street medicine's really participating in? Brett, do you want to add anything on this one?
Nope.
Great.
All right, so priority number 8, we're almost there, almost at 9, advanced data integration across health and housing. So this was based on this recommendation was based on the recognition that we're all in the same space, healthcare, housing, community-based organizations, and there's a desire to share data for the purposes of helping the patient. But all of these different data platforms that don't talk to each other, there was some hesitation to sharing data with certain government agencies, and then a lot of talk around the complexity of data sharing with needing a MOU with dozens of different organizations and how difficult that can be. And so the recommendation was really to support it to create a standardized MOU or a general opt-out clause so that people can rapidly collaborate and protect information. And then secondly was a desire to develop a tool to assess the appropriate level of care within the healthcare and housing option continuum. So as many of you know, lots of people use the VI SPDAT, which is really just a measure of vulnerability. And people have recognized the limitations of that and have developed their own vulnerability type of scale. But we're talking about a tool that will say this person needs or can do well in independent living. This person is okay or needs assisted living, skilled nursing facility. They need inpatient residential treatment, or all of the different types of services available.
Last one. There is really a very important and emerging opportunity, I think, for street medicine to be expanding legal supports for the folks that we're serving. As all of you know, there's really an escalation of legal threats, both to folks who are unhoused and the field of street medicine, but kind of more broadly, services for folks who are unhoused. And so there was a real interest in Washington around what are the opportunities for us to be able to provide real-time legal support to patients and address, a huge range of legal issues that they're facing, whether that's criminalization of survival tasks, loss of medication or ID during encampment sweeps, immigration challenges, citations for parking violations. All of those pieces we know really structure the lives and well-being of our patients. So looking into where are there medical legal partnerships that are in operation, and what do those look like either in existing street medicine programs or where's the opportunity to kind of build that out, alongside developing some legal infrastructure to support the field of street medicine. What you see here on the right is actually just about a month ago in California, a bill was passed that made it protected folks' right to provide water, food, and other kinds of supports to folks who are unhoused. So this is kind of where we're at. even in a very progressive state like California. So this kind of legal infrastructure is something that folks in California or folks in Washington have been thinking about as well. So you did it. You made it to the end with us. Those are our 9 priorities that we gathered together. Again, it's really supposed to be a bit of a North Star for the field, but just a beginning, very much an iterative process. Please download the Street Medicine Agenda when you get a second. I'll put it in the chat too. And we also just wanted to do a quick shout out to, we're doing our 7th annual Street Medicine Symposium in California. Hope you can join us. I'll put that in the chat too. And I'll stop sharing and move over to you, Laura.
Sounds good. Let me share my screen. Okay. All right. Hey, everyone. I'll try to be fast. I just wanted to quickly run through some of the recent policy changes that might be impacting street medicine and folks experiencing homelessness and living on the streets across the country. And so on the left, you'll see the policy changes. On the right, you'll see the impacts here. And so one of the big policy changes that we're concerned about, which I was touched on by Kaitlin and Brett as well, is the increase in encampment sweeps post grants pass in 2024, but also given the current administration. In July, they put out an executive order, which was calling for increased encampment sweeps, arresting individuals for living out on the streets, enforcing treatment, but also end support for housing first and harm reduction programs. And so this increase in criminalization and clearing out of encampments across the country, which has a really big impact on street medicine, as I'm sure many of you know, of just as people are increasingly criminalized and arrested and fined, we start to see those folks get pushed out and further outside of cities, which makes it harder for you all to find and provide care for them. I know Brett talked about, searching for 2 hours to find a patient. When we see encampments be cleared out and folks get pushed out, it makes it harder for us to find them and provide that care. So really concerned about that executive order and just the increase in states and localities across the country. Another policy change that Brett and Kaitlin touched on was the immigration, the increase in mass deportation that we've seen across the country in the last 8 months and the impact that that has. The administration has made it clear their priority to conduct broad and mass deportation efforts. That has included revoking sensitive location guidance, which was prohibiting ICE from entering healthcare settings and homeless shelters. We saw ICE an ICE raid at a homeless shelter in Chicago last week, 2 weeks ago. And so the impact of immigration efforts, including CMS sharing the personal data of Medicaid enrollees with ICE and DHS, and then HHS saying that health centers can no longer serve non-qualified individuals, which were mostly certain types of immigrants. And so the impact that those immigration roundups and also policy changes are having on our ability to access care. And the impact of that is that people are just really traumatized. They're afraid to go to traditional healthcare settings, to leave their homes, to access care, to go and get the care they need. And so an increased need for folks like you all to build the trust and provide care to individuals. We've heard from street medicine providers the increased need to be carrying additional medications, to be doing more outreach because folks aren't wanting to get that care elsewhere. And you all have a really unique trust built up in the community, the trust that right now I think is really lacking because of the increased ICE and just deportation efforts we're seeing across the country. The third one is the budget cuts that we've seen since the administration has taken office. Between HHS and HUD budget cuts, we've recently heard there's reporting that the continuum of care NOFO and the HUD policies will be changing. So there'll be a 2-year time limit on housing assistance, that they will prohibit housing assistance for mixed status families. And that 30% of the continuum of care funding, only 30% would be able to be spent on permanent housing. And so the impact that that will have, they're predicting about 170,000 more people will experience homelessness as a result. And so the impact of these budget cuts, while they are on the government side, are going to have a really real life impact on individuals and increase homelessness across the country. And what we know is when there are more people living on the streets, so that communities grow increasingly hostile, and we see an increase in criminalization and hostility towards those folks living on the streets. The last one I know Brett and Kaitlin also touched on was just the impact of HR 1, the One Big Beautiful Bill Act, which was passed into law and cuts Medicaid and adds just severe barriers to coverage. It's going to make it a lot harder for people to keep health insurance, whether it's the work requirements, there's more frequent redeterminations, there's address verifications. All of those provisions are going to make it really hard for folks to stay covered. As they do, we know that without coverage, they're going to experience worse health outcomes. Providers are going to lose revenue that comes as a result of Medicaid and being able to bill to Medicaid, and there'll be less services provided, and there'll be further gaps in care, again, which I think will have a huge impact on street medicine and the need for you all to provide care for folks who can no longer go to get traditional care and traditional treatment. So I think in terms of this policy agenda, there's a lot of opportunities for states to make changes, regardless of what's happening at the federal level. In terms of criminalization, encampment sweeps, the executive order that came out, states and localities have a lot of say. They're the ones that write the laws for those types of things. And so all of that is determined at the state and local level, and they have the ability to drive those responses to homelessness. And so there's a lot of opportunity there for advocacy. In terms of Medicaid cuts, although it passed into law, there's a lot of provisions that can be implemented at the state level, and the state has a lot of say in how that gets implemented, what that looks like on the ground. And so states are starting to think through what that could look like. And there's opportunities there for us to advocate as well to make sure that we're reducing the harm from those cuts and trying to keep as many people covered as possible. One of the impacts of HR 1 is the budget shortfalls that will be a result. HR 1 cuts $1 trillion over the next 10 years across the country, and many states are required to balance their budgets. And so as states start to lose that federal funding, they need to keep their budgets balanced. And so what that might look like when they start thinking through what Medicaid services they're covering, where they need to cut in order to make their budgets more balanced. And so we're not sure what that will look like, but it could mean cutting optional services like supportive housing and medical respite care. And it also make it much more difficult to expand services like street medicine because they're going to be in such financial strain. But again, I think really what needs to happen here is just a lot of advocacy to make the case for why street medicine is so critical and why investing in street medicine now can help save money in the long run. I know that business case isn't always where we want to prioritize, but I think when we think about the budget shortfalls of states, it could be really impactful right now because there's a lot of benefits to investing in street medicine. But yeah, really just need to keep pressure up on our state policy, like our state elected officials, because there is a lot of opportunities right now, regardless of the federal landscape, for them to implement policies and create change and do something good. And so I'm hoping that this agenda will help assist with that. And that's the end of mine. And I think with that, we can turn over to Q&A. Sounds good.
Brilliant.
All right. Do you want to jump in, Kaitlin?
No, you go for it, Laura. We got a couple of great
Okay.
questions in the Q&A.
Yeah, so we have about 13 minutes. And folks, if you haven't put your question in the Q&A yet, please drop it in. I'm going to start reading them out to Kaitlin and Brett, but would love to see some more in there. The first one for both of you is the metric of success for street medicine by way of stakeholders, so policymakers. Is it decreased ER visits, decreased hospitalization rates, decreased readmission rates? And if not, how are they defining success of street medicine?
You want to start, Kaitlin, or you want me to?
You go ahead.
Okay, thanks. Thanks, James. The answer is it depends on who the stakeholder is. So, it's been interesting talking to so many stakeholders. So for example, the like ED visits, readmission rate argument is not going to be useful for like your city government, for example, because they don't run the ERs. They're not funding that. It's not going to be very useful for your local FQHC who's not running the ERs. It will be very useful for hospitals who will be, especially with HR1, lots more people will be uninsured. And so they won't be billing for those visits anymore. And I think it'll also be useful for like your state Medicaid, who will be paying for some of those visits too. It's interesting. When we started our consult service in LA at the end of the year, we showed the data to the hospital that we operated out of because we told them we'd do it for free for a year. And if they liked the data, they could fund it. And we showed like 70% decrease in readmissions, 2.5 day less length of stay, 80% decrease in ED visits. And they said, that's nice. Almost all of our patients are on Medicaid. And so if your patient doesn't come with Medicaid, a different patient will come with Medicaid. And so we don't care. But I think the managed care organization would care. That's another very important stakeholder. And probably the state would care. And a private hospital would care if they have a different payer mix and they have commercial payers. So that was part of the difficulty in this conversation in DC was like, what metrics do we track that matter and to which stakeholder does this matter?
Mhm. I would just add to that. I mean, that's very helpful, Brett. And I would add, like, in the broader policy context we're in, I think there is, in terms of what metrics matter in this particular policy environment, I think there's a real opportunity for street medicine to be better articulating what is our role in supporting exits from homelessness? What does that data look like? Like telling that story, I think is going to be incredibly helpful for the field. Um, and yeah, I think there's lots of work to be done there, but I would add that in.
And on the same like metrics front, there's another question about you talked about kind of integrating. So this person's question was for housing metrics and creating something that integrates health, so you can have both in one workspace. Would this mean something different than HMIS? That's mandated by HUD. What are you thinking?
Yeah, so I mean, that definitely came up. Should we just double down on HMIS? And I think what it came down to was that HMIS, as the question said, is HUD mandated. Most street medicine programs don't receive HUD funding. And and HMIS is overseen by the COC, the Continuum of Care. There evidently has been a lot of gatekeeping on who gets access to HMIS. And so in a lot of communities, if you don't get HUD funding, they said then you don't have access to HMIS. I guess there's a fee they have to pay to grant you access. Um, and plus HMIS is not HIPAA compliant. So there was talk of a need for a HIPAA compliant platform where maybe street medicine programs could communicate with other street medicine programs and brick and mortar clinics, and then a way that non-HUD funded programs could also communicate with housing folks. And that might just mean that the COC needs to open up HMIS to non-HUD funded places. Like in Los Angeles, it took us about 2 years, but we got access to HMIS with a lot of back and forth, and now others have it too, but not everybody.
Mm.
Yeah, thanks for that, Brett. This next one I really appreciate. So for folks who are interested in getting involved in advancing the points of the roadmap, would you be able to give some specific ways?
Kaitlin, this is you.
Yeah, great question, Joy. We've been wrestling with this too. So we had funding to pull together this event and develop the agenda, and our vision with the agenda would be that it would be collectively owned by the movement, that any one of us could kind of take up leadership in any of these areas. But also what our hope is as well is to understand where there is existing work. So there are pockets of work happening in all of these areas across the country. So part of the challenge and opportunity for us now is to figure out where are leaders in each of those spaces, where are their gaps, and to pull folks together to do that collective work. In full transparency, we don't have funding to kind of, lead that whole process at the moment,
Do
but that's
everything.
what we're seeking to do. So I guess it's a double answer. One is to say, like, please see the agenda as yours and as something that you own as well, and like identify where within your community or organization or state there's opportunities to advance it. And we're hoping to be doing this national level organizing post post agenda so that and draw folks into a bit of a map building of what's there, what needs to be built. That's some of the next steps for us. Brett, what would you add?
No, that's exactly right. Our funding was to develop the agenda and hope others will pick up certain parts of it. Obviously, we're trying to pick up parts of it ourselves. We just if you don't feel like you can lead a part of the agenda, we have funding right now to develop the taxonomy of street medicine, the standards, models, definitions, and the landscape analysis. If you're interested in getting involved in those things, either of those things, feel free to email any of us, and we'd love to have you.
Yeah.
Which is great and kind of leads into the next question of have you started on any of that standards, models, definitions of street medicine? Any sense of what that looks like, if there's going to be tiers or levels to it?
Not enough to say for sure. I mean, there was a document that Jim Withers started looking at that. That's definitely needs to be updated, um, but not in the same way that it needs to be done at this point in time in our history. Um, so as I said, we haven't started it. We have funding to start it. So if it's something you're interested in, yeah, feel free to email us.
Great, thanks. This next question is from Melissa. One way to fight sweeps is to file reasonable accommodation forms for disabled encampment residents before sweeps take place. This sets up a foundation to legally challenge sweeps under ADA law and other case law. As far as advocacy, this could be a tool street medicine teams could collaborate on. Does this sound like it would be easily integrated?
Melissa, this is so great. Your leadership in this area is just really exceptional. I've learned so much from you about how to do this and the importance and value of this. Um, Absolutely agree. This is a tool that I think we could, build out both in terms of a toolkit and an approach to it. What you've been doing in California using this has been so excellent. So yeah, just to say yes, like I think there's huge opportunities there to be relying on ADA law.
Thanks. Another question here is, can you discuss any benchmarks for quality of care metrics on street medicine programs? This person says we struggle to set those for our teams compared to our clinic sites, et cetera, all of which need to be reported as an FQHC.
Yeah, I mean, those like standard quality metrics is part of what would come out of what we were talking about. I can tell you right now, if you're FQHC, well, really any street medicine program, what I would do is just pick a handful of metrics that you feel like you can track. Like for example, hypertension control would be an excellent one to choose. And like I said, we did actually start that a little bit through the collaborative. We decided we should get a small working group together to look at the HEDIS measures and figure out what would be good quality metrics. And then we had 72 people volunteer for our little working group, and and we landed on I think 10 metrics. We started with like 60 some HEDIS measures, got down to I think seven, found some that needed to be adjusted. Like I mentioned, the patient experience survey needed to be adjusted, and then added a few extra ones. Like for example, because of the high rates of hepatitis C, we added hepatitis C as a important metric. And so that's a paper that I think we're working on right now, right, Caitlin?
Yeah, yes, in process.
Great. Well, we have a couple minutes if there's any other questions that pop up. I know someone asked for our emails, dropped those in the chat. So if you want those, everyone should have access to them there. I saw that the slides are going to be sent out later.
Yes, we're sending out the slides and recordings, so feel free to circulate to friends and colleagues. I also added in the chat a link to register for the California Street Medicine Symposium. We'd love to have you join us wherever you're from. Yeah, and maybe we'll give you back a couple minutes of time. Brett, do you have anything you want to share before we close out?
Oh, Liz asked if there's a plan for meeting together again.
Oh,
I mean,
nice.
yeah. We haven't talked, Liz, well, we should talk about it. So for those of you, Liz is the chair of the Street Medicine Institute. Um, but well, yeah, we'll have to think about what we need to do. But today was
Yeah,
just, yeah.
yeah, yeah. I'll also just to raise up, the Street Medicine Institute is doing a series of webinars this fall. We just had Laura join us, I think last week, to talk about the federal policy changes and challenges that we're facing for the field. So we're going to be doing another one on the executive order around homelessness, and then one on immigration and ICE. So hopefully you'll join us for those as well. But yeah, thank you all so much for being here with us. This was just wonderful. Thank you to all the teams that hosted us across the country to hear from folks who are living on the street about what's important to them. And our hope is really that, yeah, you own this agenda. Please, please take it up in whatever way is helpful. This will be something that we hope will evolve in years to come, but is really hopefully a North Star for all of us in really remarkable times. So sending all of you so much solidarity and care, and thank you to the National Healthcare for the Homeless Council for having this webinar with us too, and our funders. There's just many wonderful people who help make this happen. So thank you to everyone.
Great. Thank you, everybody. Have a great day.
Thanks,
Thanks all.
everyone. Bye.
Bye.